Morning, everybody. Welcome to the Penn CFAR Scientific Symposium 2020, which is also a workshop. Let me share my screen here. I'm Ron Collman. I'm director of the Penn CFAR, and it is really a pleasure to have all of you here. So this scientific symposium is co-sponsored with the Penn Implementation Science Center of the Leonard Davis Institute, and our goal is to focus on creating and strengthening cross-collaborative partnerships to end the HIV epidemic in Philadelphia through implementation science. And this really is a work produced by our scientific working group, Implementation Science in Philadelphia to End the HIV Epidemic Regionally. When I looked over the list of registrants, I saw that it's really quite broad, and I thought that there may be some people who aren't familiar with what a CFAR is or what the Penn CFAR particularly does. So the Penn CFAR is a collaboration between three institutions, University of Pennsylvania, Children's Hospital of Philadelphia, and the Wistar Institute. And we have members, about 200 faculty from all three institutions, 11 of the schools within the university, and a fabulous community advisory board that serves as our link to the community. And we have several really tightly interwoven collaborating partners. And particularly relevant for this morning's presentations is the Philadelphia Department of Public Health. There are 17 NIH-funded centers for AIDS research across the country, and I want to point out that here in the Mid-Atlantic region, we work really closely with the other CFARs at Johns Hopkins University in Baltimore and the District of Columbia CFAR in Washington, D.C., to focus on issues addressing the HIV epidemic in our Mid-Atlantic region, our urban areas. The CFAR does a lot of stuff, and this is kind of my boilerplate description of what are the things the CFAR tries to do. But I want to focus today on what do we want to do with this workshop, this symposium. And one of the key goals is to develop new partnerships to advance science and have impact. We really want to use this as a platform to catalyze new high priority and interdisciplinary research. Engaging with the community with bidirectional communication and the establishment of collaborations is another key goal. Outreach to draw in non-AIDS investigators to the field. There's tremendous expertise in implementation science that we want to bring to have them focus on the HIV epidemic. We have fabulous inter-CFAR collaborations with Baltimore and DC to leverage the network. And like all things that the CFAR does, we want to create partnerships for established investigators who are new to HIV and mentoring for young investigators. So that's a big part of what we're trying to do here this morning. So I'm a virologist, and this is a snapshot of data that we're going to hear from experts over the course of this morning, but these are some of the things that really strike me. In the US, we have over 1 million people living with HIV. There still are nearly 40,000 new infections a year, and it's incredibly disproportionately overrepresented in African Americans. And this is a statistic that really boggles my mind. For an African American man who has sex with men, an African American MSM currently is estimated to have about a 1 in 2 lifetime risk of becoming infected with HIV. And that is many-fold higher than white MSM. And as a white MSM myself, I find this to be an incredibly staggering statistic. Adolescents are the fastest growing segment of new infections, and that really is a tragedy. So everybody on this symposium knows about the Ending the HIV Epidemic Plan for America. The goal is to reduce by 75% new infections 5 years from rollout of the program and 90% in 10 years. And there are among the 3,000 counties across the U.S., only 48 of them, 7 rural areas, DC and San Juan, Puerto Rico account for more than 50% of the new diagnoses. Obviously, Philadelphia, Baltimore and DC are among them. And this is a map of Philadelphia with our HIV prevalence. And here's Penn right here in the epicenter. So, I spend my career focusing on the biology of the science, but we have effective treatment and we have effective prevention strategies, but they have insufficient impact. Everyone here is familiar with the continuum of care, whereby we have 100% perfectly effective drugs and not all people are virally suppressed. We have great medications to prevent infection, but PrEP uptake, as we can see here, this is the proportion of the new infections among the Black population, and yet here's the proportion of PrEP uptake in the Black population as an example. So we have the tools, and obviously implementation is the gap. So we have two key partnerships that I want to highlight here in this introduction. The Department of Public Health, the AIDS Activities Coordinating Office, and we established this partnership a few years ago with a goal to align CFAR research with the goals of the PDP to support and advance the End the HIV Epidemic regionally, the Department of Public Health's mission. We're going to hear this morning from Collman Terrell, Director of the AIDS Activity Coordinating Office, and Kathleen Brady, who is not only Medical Director and Chief Epidemiologist of ACO, but is also a member of the CFAR Governing Administrative Corps. And I'm sure we're going to hear this morning about the new End the HIV Epidemic plan that the Department of Public Health released just earlier this week. So the next key partnership is with the Implementation Science Group here at Penn and the Leonard Davis Institute of Health Economics. This is a new partnership, and it's manifest in our new scientific working group, Implementation Science to End the HIV Epidemic in Philadelphia regionally. And I'm grateful to the leadership of this scientific working group, Ronald, head of PICE, Florence Montplaisir in infectious disease, and Steve Meanley from the School of Nursing. And so this scientific working group is leading this initiative, and we're really excited to have this program launching. So without further ado, I want to thank everybody for being here. This is a symposium, it's a workshop, but it really has some goals. Our deliverables are to share knowledge and experience, and really to develop new collaborations and research projects to inform and advance the EHE mission. So I'd like to thank you for being here and introduce Kathleen Brady, who will introduce our keynote speaker, who we are really excited to have joining us this morning. Thank you.
Thanks, Ron. And so on behalf of the Philadelphia Department of Public Health, I want to welcome everyone to the symposium this morning. As Ron outlined, the Penn CFAR has a formal collaboration with the Health Department here in Philadelphia that is actually modeled after the public-private partnership of the DC CFAR and the DC Department of Health. And so as Ron mentioned, I serve as a member of the Penn CFAR Administrative Corps, and now, hopefully, I think, a member of the ICER SWIG. I was introduced to implementation science only a little over a year ago at the HIV Implementation Science Summit for Ending the HIV Epidemic Supplement projects held by the Third Coast CFAR at Chicago. I immediately recognized the power and impact that implementation science could have on evaluating health department EHE initiatives, both new and old. And as you'll hear soon from my colleagues at the Health Department, federal funding for Philadelphia and other priority jurisdictions that we've received for EHE is ridiculously small to meet the lofty goals of this initiative. In order to end the HIV epidemic in Philadelphia, we need to leverage all available resources, including research funding to implement highly effective programs and to modify current programs so they can reach their maximum impact. You'll hear a little later on this morning from my colleagues who will talk about the community plan to end the HIV epidemic, some barriers to achieving the goals of EHE, and finally, some of the implementation science research priorities for ending the HIV epidemic. So I want to thank you all for attending today. And actually, my next task is to introduce you to Florence Montplaisir, who will introduce you to the keynote speaker this morning. Dr. Montplaisir trained in infectious diseases at Temple University Hospital and obtained her Master's of Science in Health Policy Research at the University of Pennsylvania. Before coming to Penn in 2019, she was faculty at Drexel, where she developed a behavioral-led peer intervention to improve retention and viral suppression for pregnant and postpartum women living with HIV that is now testing in an R01 funded study. She is co-lead of the iSphere SWIG with Drs. Bates and Meanley, which seeks to support the development of community academic partnerships to create capacity for collaboration on work at the intersection of HIV prevention, HIV treatment, intervention, and implementation science, and the service of ending the HIV epidemic. She is a multi-PI in an R01 funded study using community health workers to improve retention and care and viral suppression across 12 clinics in Philadelphia, many of whom are attending the symposium today. So that's actually the more formal introduction. I do have a little bit of a personal one. I first met Florence back in 2010 or 2011 when she was a general internal medicine fellow at Penn while she was getting her Master's of Science in Health Policy Research. It was easy to see her talent and potential as a researcher at that time. And I was so pleased that she decided to pursue an ID fellowship, even though she was completing her internal medicine fellowship at the time. Our collaborations have continued while she completed her fellowship at Temple and her first academic faculty position at Drexel. I'm happy to have been one of her mentors in her early career development. Florence and I have collaborated numerous times and actually have 12 publications together. There comes a time, however, when the mentee surpasses the mentor, and that time has come with Florence. I'm so proud that she has joined the faculty at Penn a little over a year ago to see her get her first R01 and to become the leader that she is today. And she's done it all with grace, kindness, but also passion for her work. Not all heroes wear capes, mine doesn't, and so I'd like to introduce my hero, Dr. Florence Montplaisir. Thank you.
Oh my goodness, Kathleen, you're gonna make me wanna cry. I thank you so much for this very gracious introduction, and really thank you for your mentorship and honestly your friendship throughout these years. I'd like to welcome everyone. We're very excited about this symposium, and we're very excited that you were able to join us today. And my task is to introduce the keynote speakers. So the Ending the HIV Epidemic plans puts community at the center of HIV elimination efforts, calls for us to push boundaries of our existing healthcare system in order to reach the most vulnerable. Today, I'm honored to present the keynote speakers, Dr. Vicki Cargill, Dr. Jason Farley, and Ms. Nikita Wilson, who will share their joint experience doing just that and using community health workers to get to zero in Baltimore. Dr. Victoria Cargill, or Vicki, is an Assistant Commissioner of Health at the Baltimore City Health Department, responsible for the wine-wide program and the syringe services program. Before joining the Baltimore City Health Department, Dr. Cargill had a long career at the National Institutes of Health, where she served as a Director of Minority Research and Clinical Studies in the Office of AIDS Research, and then transitioned to the Office of Research on Women's Health in 2016. Dr. Jason Farley is a professor of nursing at the Johns Hopkins University School of Nursing. He's an infectious disease trained nurse epidemiologist, a nurse practitioner in the Division of Infectious Diseases at the Johns Hopkins School of Medicine. He is creator of the REACH initiative, which serves Baltimore City residents living with and at risk for HIV by expanding access to HIV and PrEP testing, linkage, and engagement in care. He's also the creator of Getting to Zero model and conducted the original pilot work at the Johns Hopkins Bartlett Clinic. Nikita Wilson is an HIV case manager at the Johns Hopkins University with an extensive background working with special populations throughout the Baltimore region. By building trust, she's able to link persons living with HIV to much needed services to help move the needle to getting to zero. So we're very excited to hear from our keynote speakers. I think just the fact that it's a multidisciplinary team having different perspectives and working together toward getting to zero is very exciting. We hope that this talk will generate a robust discussion around the use of multidisciplinary models to meet the EHE goals. Please include your questions and comments in the Q&A portion, and we will use them as a guide for discussion after the keynote address and during the panel discussion section of the symposium. Thank you very much, and I will turn it over to our keynote speakers.
Well, good morning, and thank you so much, Dr. Monplaisir. It's such an honor to come back to Penn. As you can see from my letters behind my name, I have a heritage that stands back to the university. And it's really exciting to be able to present what has really become a wonderful collaboration with my colleagues at the Johns Hopkins CFAR and at the REACH. So without further ado, let's go ahead and talk about this. I like to put things in context, so let's have the next slide, please. Some of you may recognize this individual, but I think it does help us to set the stage. And this is Mr. Len Bias. Mr. Bias was the first-round draft pick for the Baltimore Celtics and was really on his way to an exceptional career, except unfortunately he died from a cocaine experience before he could even begin to play for the Celtics, and really began to, I think, it crystallized what the experience was in Baltimore at that time. Next slide. And as you can see here, as we show you this graphic of the really meteoric rise of HIV and AIDS cases in the city, beginning in 1986 all the way through to 2010. And if we push, I think, the downward arrow, you can see that at this point when these numbers were compiled, it was estimated that we're still looking at perhaps 20% or even more being undiagnosed. So clearly during a time when HIV and AIDS was just rampant in the city. Next slide. This comes from the publication, one of the many from the ALIVE cohort, and the ALIVE cohort, ALIVE standing for the AIDS linked to the intravenous experience, funded by the National Institute on Drug Abuse. And one of the reasons I show this slide is so that you can see the quick decline in incidence of HIV infection among those who injected drugs. Baltimore had a robust, if that's the word you can use, epidemic among injection drug users, to the extent that back in the 1980s, it was approximately 2 out of every 3 injection drug users was HIV positive. And with the intervention of both the ALIVE and, more importantly, a syringe support program that is still quite robust even today, that was able to be decreased to where we are between 6.4 and 7.2% as compared to the early days of 67%. Next slide. We also were experiencing in the city this decline in cases, and I could even take you as far back as 2012 and see that although it wasn't consistent in, we did have inter-year variation, the overall trend was moving from 500 to 400 to 318, 278, 227, and 224 as we continued to have a decline in cases, meaning we were beginning to now be on track to meeting the national HIV/AIDS goals. Next slide. In addition, there was an improving rate of viral suppression. We saw in Dr. Collman's slide the cascade, and this is the cascade here for the Baltimore, Towson EMA. I would point out that Ryan White in general has been very fortunate, has been able to do better than the national average, which can vary between 55 to 65% virologic suppression, whereas in Ryan White overall, we've been able to get to 89%. With the time this slide was done, you can see that we were at about 85%. We are now, recently, we just ran our data in Baltimore, and we are fortunate we are now at 90%. So that we're making strides, but while we make strides, there are still those who obviously we still can't connect engage, or retain. Next slide. So just to put this into perspective, this clearly was the right time. The opportunity was coming. We had decreasing cases, transmission patterns were changing, and that we could see that people living with HIV were no longer reflected in the injection drug use risk, but there were other behaviors. We knew that engagement wasn't going to be easy, however. We couldn't afford to be complacent and say, well, we have this great viral load suppression, because on the other hand, it meant there were individuals who were still not reaching. And so it would require listening. And this work reflects that in combination and collaboration with our prevention side and Dr. Adina Greenbaum, we conducted listening sessions as part of our creating the Baltimore Ending the HIV Epidemic Plan. And one of the opportunities that emerged was to be able to have not only focus groups, but listening sessions, community feedback sessions. At the time that we envisioned this and wrote this, we were well over 100. We're now creeping up on 150 of these and continue to go forward. This also provided an opportunity for us to build new collaborations as well as expanding existing ones, and more importantly, to think outside of the box, to engage across sectors, across communities, and across agencies, so that we could then incorporate this critical feedback that we were getting from consumers and advocates as well as stakeholders into our activities. And so this allowed us to begin to really think about how we could build upon this tremendous Johns Hopkins Bartlett Clinic experience. And I can say that there were stories that were shared with us during these listening groups that really stayed with me and made me even more determined that we were going to incorporate that into our model. And you'll hear about this in a few more slides. Next slide. So the overall mission, of course, is to have virologic suppression, because we know virologic suppression not only contributes to better health outcomes, but it also helps with community viral load and decreasing transmission. So we knew that the Getting to Zero Plus community health worker was going to be in a clinical setting. However, we also need that individual to be in a mobile setting. And this is where the feedback from advocates and consumers and stakeholders was absolutely essential, that there were individuals 15, 20, 25 years past their original HIV diagnosis who could speak with painful affect about what it was like to test positive at 10, 11 o'clock, 1, 2 o'clock when we're doing our outreach, and there's nowhere to go for support. There's nowhere to go to talk this through. You can't go to the emergency room because the individual says, you've already been told, what can we do for you? So we knew that was going to be important. We knew it was important for community health workers to be able to link and engage individuals in HIV care with, of course, maintaining linkage and improving health outcomes, as well as maintaining viral suppression. But it was also going to be important to reduce transmission and to, in those cases where we experienced a new case, to be able to be faster in our response. So really Getting to Zero Plus was created to target those reservoirs of either undiagnosed, unengaged, virally unsuppressed individuals with a focus on youth, young, same gender-loving men, racial and ethnic minority women, those who were formerly incarcerated, and certainly those who are marginally housed. And so the Getting to Zero Plus community health worker-based linkage and engagement program was really customized to meet the needs of each targeted population as we described in our methods. Next slide. And I love this term, and I have to give this credit to the REACH team, especially Dr. Farley, of this being unapologetically enabling, meaning what? Removing any potential barriers to linkage and access, care engagement, care retention, adherence, and as you'll see in the other presenters, that our definition of retention may not necessarily equate to an individual receiving benefit. As well as focusing on community solutions, that programs that go beyond the brick and mortar, that they create opportunities outside of our traditional clinical spaces, such as, do you need support or you want someone to accompany you to visit? Can we meet at the coffee shop? Should we meet at the corner? People at home don't know that you're living with this. So how can we help you with this? Facilitating communication outside of traditional clinic hours. This was a piece, again, that was fed back to us repeatedly from consumers and from advocates. We want to honor that, as well as trying to support this new type of client navigator relationship. And I have to give credit to our DIS workers that when I said to them, listen, one of the things we've been told is telling your story over and over and over again is very traumatizing. Is there a way that we could do this so that we can minimize that but still meet the objectives of the CHW and the DIS? And they came up with the CHW-DIS hybrid, that after doing all the mandatory partner services interview, being able to slide off that hat and say, okay, now what can I do for you? Can we give you a gift card? Can I attend with you? Ways that will really help individuals. Next slide. And so with that brief overview, I'm going to go ahead and turn it over to my wonderful colleagues, starting with Dr. Farley. Thank you.
Well, good morning, everyone, and it's a pleasure to be with the Penn CFAR. I am a clinical core co-director at the Hopkins CFAR, and like Dr. Collman said, it really is a wonderful collaboration between the groups. So when we were thinking about our Getting to Zero program, we were really thinking around those goals of 90-90. And in its pilot form, we were still at the point of really having about an 85% viral suppression and really thinking about that final 15% and what services we need in our Ryan White clinic. So the Bartlett Clinic is a Ryan White clinic. It is structured so that all of the necessary wraparound services are co-located together: social work, behavioral health, and many others. And we have linkage and adherence programs. And yet still in that circumstance, we also have, I should say, one important thing, we have peer advocates within our clinic. So within that circumstance of the appropriate wraparound services, the peer advocates, social work, mental health, substance use providers, we were still sitting with about 15% of our patients who weren't virally suppressed. And so we really started to think around how we would change the lives of those 15%. And so really, based on the experience, as Dr. Cargill was mentioning, we really wanted to focus on those patients who are either out of care or virally unsuppressed and in care. And so most of our Ryan White patients had some level of engagement in our care services. So we began, as classic to do, with a needs assessment. And we really, in listening to our clients, that listening session that Dr. Cargill was mentioning, these 8 issues really were continual themes. These are not unfamiliar to all of the activities that you are probably engaged with. And we really felt, that lack of coordination to help individuals navigate these services. And really that not the lack of coordination within a Ryan White clinic. There was great services within the brick and mortar, but was really all about what was happening in the community. How were we addressing these issues and barriers to actual care that prevented patients from engaging? And so when we were thought about the pillars of our GTZ plan, it really began with an education capacity building and information dissemination for clinics. We wanted to model what it meant to be a Getting to Zero clinic. And with starting with the John Bartlett Clinic, many of you may know it as the Moore Clinic before it was renamed to the Bartlett practice. We really wanted our providers to know we believed and fundamentally knew that they were experts in the care they were providing. And that if you looked across each individual provider's panel, they may have only 5 or 10 patients, but when you put that across 30 plus providers, 5 or 10 added up. And so what we really wanted to say and take with this pilot was our largest volume providers, those who had caseloads of 500 patients or more, and really think about how on their panel list, their line list of patients, how could we help them as a Getting to Zero provider, one provider at a time, think about how we might support them and their patients. We provided a FTE support, and Nikita Wilson is our community health worker who has grown with this program and really worked with us throughout this process. You'll get to meet her shortly. But we also provided technical assistance to the clinics in making sure the HIV testing linkage to care support was present, navigator support training, so that it wasn't just our GTZ model, but all peer navigators understood the role of the new GTZ navigator, and then providing them data management support. And really, that data management support had to do with helping them ensure that the CareWare data was entered. And we did use the CareWare data system as a key informant to develop and provide the line list of patients for our providers. Now, in our clinic in Baltimore, many clinics use the CareWare system for data entry, but it's not often used as a means to determine who might be virally unsuppressed. And in providers with large volumes, it could be a critical way of running reports to help them identify who on their panel is virally unsuppressed. And I'll show you our data mapping plan to do that in the next slide. And we wanted to make sure that there was a robust evaluation of the intervention impact and effect. And when we thought about this process and how we would get a provider their individual list of patients without viral suppression, we had to go through a pretty robust process to understand what the CareWare data report could offer us. And what you can see here is that starting with the unique elements of CareWare, we established a line listing with some filter settings related specifically to those who had viral loads greater than 20, and then created this ongoing provider list by clinic site. And I call that a work in progress on this data flow diagram because it's constantly updated. It's constantly provided with, we add new providers all the time, and providers, patients, move from viral suppression into that virally unsuppressed group. And then our GTZ navigators work with the provider, look at the medical record, do chart abstraction, help to identify what category of patient the individual falls into. Are they completely lost to follow-up? And in that case, we have to get our DIS and health department colleagues involved because they have not been seen in greater than 6 months in the clinic. Are they engaged but not on ART? And then that's an intervention, with the provider. Or are they engaged on ART and not virally suppressed? And then those who have inconsistent engagement. And that seesaw in and out of care is a big area in which we try to help support. Our GTZ interventions we'll go through in a couple of slides. I won't belabor this point here. We situate this model really importantly in a behavioral approach to care engagement and adherence called the Information, Motivation, and Behavioral Skills model. And in particular, we use the situated model, which layers on the sociocultural, institutional, interpersonal, and intrapersonal aspects of care, because we know that our patients who don't have viral suppression are facing many intersectional challenges that may be above and beyond and influencing the care they receive, but it really speaks to that getting out of the brick and mortar and into the community and all the issues and barriers that are faced in the community. And as you can see here, one of the things I like about the IMB model is that it does really help to foster and facilitate a model that's straightforward and really works well with a community health worker for engagement. And we really message a lot around during what information is the right kind of leveling for that patient, what is their individual motivations, and Nikita will present a great case study on a patient's motivation, and how do we influence certain specific behavioral skills like pill taking and other forms of adherence. So initially, our outreach worker or community health worker will outreach to the patient via phone. Obviously, this has transitioned remarkably during COVID, but they conduct a barrier assessment and schedule a time for a face-to-face meeting in which they do all of these additional intakes with the patient, really trying to address the immediacy of any psychosocial needs. Housing, and as you can see from other things, substance use disorder, nutrition, food insecurity is a big issue, particularly now with COVID, but it has been for quite a while. Emotional support, and that active listening component of emotional support, that time that providers just don't have in the clinic to give. And then helping with clothing and hygiene products, and Nikita will present some data on that. We really wanted to make sure that the navigator, thus the reason providing the FTE to the clinic, was fully able to build trust and actively listen in whatever time frame that was required for that patient, and really help navigate clinic systems by meeting in person, helping the patient, navigate phone trees. We don't think about when you call to a clinic and you get a really difficult phone tree to follow. We all know that we're trying to hit the 0 to get to a human being. And in patients who may have burner phones or phones that particularly have to pay for airtime, that's a use of their very precious resource. And the community health workers knowing how to get through that system and connect the patient once they've got a live person was a key component that we've received feedback on. That retention and care aspect of this has really built on that adherence support in the long game. We don't believe that we need to force patients towards viral suppression immediately, and we'll have a great case study around that. But helping them navigate with text reminders, motivational messaging about how great it is to see them even take a single pill has been really critical. So our data from July 2019 through May of 2020 enrolled 136 eligible patients who had detectable viral loads. And Nikita, our GTZ navigator, was able to reach 126 of them, so 90%. 90% were male, 90% Black, 81% were 35 years of age or older. That probably speaks to more of our clinic demographic and our adolescent clinic fostering and caring for patients about to the age of 25 before they really transition them over to our adult clinic in many cases. 30% reported MSM or same gender loving background, and 25% had injection drug use as an exposure. Now, among patients who had at least one repeat viral load, 70% or 79 of these achieved viral suppression, and 20% of those sustained viral suppression, defined as less than 200 copies in this analysis, for greater than 6 months. Now, importantly, this really reflects the ability to get patients virally suppressed, but the lability sometimes that we experience with that viral suppression. When we think about dose and the level of intervention for the community health workers, 35% of patients received greater than 10 encounters, with an average of 8 encounters for patients who were virally suppressed, but almost as many encounters for patients who did not achieve viral suppression during this interval. 30% of these encounters were face-to-face and 70% were telephone-based. And importantly, the visit was primarily related to important scheduling, reminders, transportation, again, that emotional support, but also healthcare system navigation. The advocacy in both the clinic and the community was a very common request. I'm not having this great conversation with my provider. They're not understanding, hey, I need social services to respond to my call in patient time and not in healthcare worker time, was a big request. But we did not measure the time on task. And one of the things we're correcting with the expansion of this is a time on task for the community health worker. If it took the 5 hours to resolve the patient's issue versus 5 minutes, we didn't capture that with this initial pilot. So we did provide, this is an initial case details of a 38-year-old female who was a patient of Nikita's, who was diagnosed in 2009 during pregnancy. The Bartlett, she was a brand new patient in June of 2019 with a CD4 nadir of 3, some weight loss, a low BMI, and multiple comorbidities. And I really wanted to present this case and start this off before Nikita takes over, because from a provider perspective, you might look at this and go, wow, that is a really medically complicated patient who's not virally suppressed. How would our community health worker be able to intervene here? And from a medical history perspective, and looking only at her background of her little line list here of her CD4 counts, viral loads, and medication strategy, you would probably say, oh, wow, this would not be a community health worker patient. But what I wanted to show in June of 2019 was her first visit at Bartlett. Her viral load was 14,000 copies. She had a significant anemia. Her CD4 count was 3. She's had, as you can see in red here, multiple hospitalizations. By July, she had her first GTZ contact. She was supposedly on a regimen of darunavir, boosted darunavir with FTC and TAF, however, was not ultimately taking it, but she kept telling the provider she was taking her therapy. So then the provider said, oh, well, you just don't like pills. Let me switch you to liquid regimen. and the patient wasn't tolerating any form of liquid therapy as well. And so really when Nikita was engaged and involved, you can see how she took her 115 interactions with this patient. And as of June 2020, the patient became virally suppressed. And I'm so happy to turn this over to Nikita Wilson. Nikita is our community health worker. And when she started with us, she did not have those MPH letters at the end of her name. She was a case manager and had been working in Project Place, which is a community-based organization, and subsequently completed her MPH. And I would say, Nikita, I'll let you take it from here and tell us this wonderful story of success.
Oh, thank you so much, Dr. Farley. I really do appreciate it. And thank you, everybody here at Penn, for having us be the keynote speakers. I really, really do appreciate it. And so with my background, as Jason did state, I was previously working with the homeless shelter and working with these special populations throughout the Baltimore region. Either it be trans, youth, and all persons living with HIV. I was able to help them get connected with the services. Some of these services either being housing, transportation, care navigation, either HIV education, getting those budgets together for whatever the case may be. Go ahead, next slide, Jason. Thank you. And then so with this particular case, my patient, when I did my initial intake with her, she had a 10-year-old son who has autism. He also, with his childcare, the childcare provider had mental health concerns, resulting in a very complicated consecutive childcare for him. She also is an employed individual who worked for the state for DSS, so she understands the some of these services that I could offer to her, but she, even as a full-time worker, was not able to have. And so she was missing out on her job a lot of the times where she was being in the hospital. And this has resulted in frequent pending evictions because she wasn't able to keep up with her rent and her bills with not being at work, right? And so her son did not have a bus pass, and so any of her money that she did have, she was using that on some of her Uber expenses, and to get him to his childcare as well as to and from her own doctor's appointments. And being that she is a worker, right, she also was using her money to come to the clinic on her lunch appointments. And so with her, that being a small, hour lunch break, getting an Uber to and from work was a lot of her money going towards just transportation. So transportation was a huge barrier for her. And then so after that, not having any more money, she wasn't able to really focus on her medication or trying to make sure she had this money for it, right? I'm going to use my money for other things. Medication's not my main concern right now. So she wasn't able to pay for any of those co-pays. Okay, next slide. And so with me being the navigator, I had to develop that strong communication with the other members that were in my patient's care team. So whether that be social work, nurses, and especially with the provider, with having that communication with them, all of my patient's needs were being addressed in a timely manner. So like as we spoke earlier about the phone tree, it was saving her a tremendous amount of time from having to, go through the phone tree. Hey, this is my concern. I'm having some issues. Is it okay if you can, get me in the same day appointment? Most of the time you call and do the phone tree and be trying to get somebody on the phone, but it was easier for me to call the nurse or just send an email real quick and then be able to get them seen the same day after expressing whatever my patient would call in and say that what was going on with her. Also, with having that good communication, we were able to get her any of her redetermination paperwork signed up for her drug assistant program, covering her job, right? She works full time and she needed to make sure she had this paperwork for leave of absence during these hospitalizations. I also want to point out when she was claiming that she is, she's technically our engaged patient, and that she was having issues with taking her medication and having that transition from the nasty liquid that she was put on while she was in the hospital, back transitioning to taking her pills. And let's see here. Oh yeah, the FAAN. Go ahead, next slide. Alrighty, and this patient has accumulated a total cost of $939.34, and this is the direct cost for her. This is not including her housing expenses. Some other things, just what the expenses did include was her medication copay support, Ubers, not just to and from work, but sometimes that childcare to get them to and from daycare, as well as to any of her other medical appointments to make sure that, hey, don't worry, we got your back. Don't, save your money for your rent and, budgeting the things out that you do need. We also, provided gift cards for food. Sometimes meeting her on those lunch breaks and she's hungry, right? We got to make sure she eats. She's leaving work. So we will provide her some money for her to be able to get some lunch. And also with giving her some clothing, household items, personal hygiene, not only for herself, but for her son. And with the self-care management, we did purchase this really cool pill box water bottle. That way she can take it on her lunch break while she's at work. And we also set up calendars with her and monthly, yearly calendars, and just making sure that she's able to budget out all of her stuff. And also, I was able to arrange her to have stable housing where her evictions that she was getting, the Project Place was able to help her prevent that eviction by paying her rent for 2 months while she was hospitalized. So, with all that being said, although she was a very complex patient for me, after having her for all this long time, and we're still in communication, after a long year of working together, I'm very, very happy to say that she was able to achieve that viral suppression. And I'm so happy to be able to have worked with her, and she's still maintaining that viral suppression since June of 2020. But thank you again, everyone. I do appreciate it.
So one of the things that once we completed this pilot and were able to talk to Dr. Cargill about was a large 5-year HRSA cooperative agreement through Ryan White Part A and B. And Dr. Cargill is the PI of this, and we've integrated the GTZ program that we designed at a clinic. And as she mentioned before, really increased that and expanding it into the community even further, including our syringe support services as they engage with clients and have newly diagnosed patients. Also our block and blitz programs that help women engaged in sex work, as well having a navigator. Really thoughtful approaches into the community, being able to help facilitate the work from the start of the point of entry into care, which is potentially that HIV diagnosis in the field. Mm-hmm. So just really been very happy to see this work expanded. We now have multiple clinics involved, so Family Health Centers of Baltimore, as well as our syringe support services, as I was mentioning. As well as New Vision House of Hope, which is a housing provider that offers housing for people living with HIV. And in our next year's additional federally qualified health centers in year 2 will be coming on board. I also failed to mention our Star Track provider team, which is our adolescent team at the University of Maryland, is now on board in our first year of implementation. And we're starting to get our community health workers into the field and really engaging in year 1. So there are a lot of people to acknowledge, and as Dr. Cargill mentioned, Dr. Adina Greenbaum at the Baltimore City Health Department, the GTZ pilot was actually in the prevention side of things with our EIS funding, our Early Intervention Services funding at the Health Department, and our program officers at the Health Department, Ashley Price and Adam Hubner. My team at the REACH Initiative, Kelly Lowenson, Nikita Wilson, Nikita who's here with us today, Kelly who is a nurse case manager and AIDS certified registered nurse, who is helping support Nikita and have her back when she needed to escalate things Dr. Tamara Rodney, who's a psych mental health nurse practitioner, helping us tailor this intervention as we grow for patients with mental health needs, and particularly those mental health needs that aren't met in our brick and mortar spaces. And our Bartlett specialty practice, Dr. Joyce Jones, who's assistant medical director of that clinic, as well as Rebecca Diaz-Reyes, who is our CareWare data manager at the clinic, both instrumental in helping us stand up this approach at the Bartlett service. And then finally, you know, when you find that great colleague and that kindred spirit, when I was talking with Dr. Cargill and Dr. Ferrari about the role and the model that we had at the single clinic and about the potential opportunity for expansion, I just have to say that that academic public health partnership could not have been stronger, and the visionary leadership of this team has just been a pleasure to work with. And so to see that same model here at Penn has been really great to hear about this morning in our pre-call meeting. Also, I'd like to thank Stefan Effinger, who is managing CareWare for the entire city of Baltimore, because we would not be able to do this without really thoughtful planning on CareWare support, because each agency has different CareWare logistics that have to be worked out as you go to implement this project. So with that, thank you very much, and I think we're all happy to take questions that you may have.
Thank you so much for an amazing talk. We do have one question in the Q&A, and please submit your questions in the Q&A. So this is a question from Dr. Michael Blank, and this is addressed to Vicki, but anyone in the panel is also welcome to weigh in after Vicki. My colleagues and I worked with the CDC over a decade ago to measure the rates of HIV among people in Baltimore and Philadelphia receiving mental health services, and found 4 times the rates of HIV compared to the general populations of those cities. Why isn't HIV testing routine in CMHCs? I assume community mental health programs.
I'm not sure that I can necessarily address why it is or is not. I don't oversee community mental health programs. I do know that we have robust HIV testing. We have, up until the pandemic hit, multiple mobile service vans throughout. So we've heard of some of them. We have our syringe support van, for example, that conducts routinely HIV testing. We have the reproductive health van, which is partnered with our syringe support van, that works on the block. And for those who may not know Baltimore, it's that section of strip clubs. So it's conducted there. We have community partners such as STAR that also reaches out the block into other communities. In addition, we have the Blitz, which was designed really to address our epidemic, which I now say is endemic with syphilis. So again, I can't really speak to the community mental health centers. We do know that our family health centers and our community-based organizations have really ramped up not only their HIV testing, but we now have syringe support services based not just on the syringe support van, but I can think of at least 5 or 6 community-based organizations right now that are doing this, including backpacking into areas where we have seen complete decimation of neighborhoods, and they're basically people squatting in homes, and they're also doing rapid HIV testing. So that may have been the case at the time. I can't speak again to the community mental health centers, but I can say that we have been blanketing the city with HIV testing. Now, some of that has become difficult with the pandemic. I'm not going to say it's been easy. Many of the mobile services have come off the street. Syringe support has never come off. I supervise the staff, and at one point I actually pressed them pretty firmly to consider coming off of the street, and they refused. But instead, we came up with ways prior to being able to obtain sufficient PPE to do this in a very safe way. We have, unfortunately, like everyone else, had our experiences. We've had staff become sick. We've had one staff person who became ill and lost 3 family members at the same time from this. But we persevere, and the idea is to continue to have a protocol that will allow us to do that, so that even if our community mental health centers may not be doing this, we have this blanketed throughout the city for HIV testing, and we are continuing to test. I
would just add that as from our side within the REACH initiative, we're also an AIDS education training center. We're with Pittsburgh in the Mid-Atlantic region, and the question is spot on. We often lack testing. Our focus through our AETC has been to increase testing through our medication-assisted therapy clinics, or our MAT centers, because of the just stability of those patients. It's my understanding, though, in terms of often why HIV testing is not done either at community mental health centers or primary care offices in general, right, meeting CDC guidelines of everyone having a test between those ages of 18 and 65, is that the reimbursement model for mental health providers is not overly supportive for doing HIV testing. And oftentimes they don't have the supportive linkage infrastructure in place. But it's a very good question, and we're making inroads into MAT centers, but the community mental health centers are lagging behind, like our general primary care center.
Thank you. And we're going to hear from the Philadelphia Health Department soon, particularly around the EHE goals for Philadelphia. But one of the points made in the report is that we cannot expect patients to change. We need to expect health system to change in order to, like you said, enable, just not be apologetic about enabling. And I wonder if you can speak to this a little bit, like how can our healthcare system or clinics and as providers, what can we do in order to reach that 15% that you mentioned who are not virally suppressed and not retained in care?
Yeah, so when we talk about unapologetically enabling, we mean it to its purest form. So any barrier that the patient identifies, and so that 115 encounters that Nikita had with this client, the first 6 months of those encounters really only had Nikita working on this patient's son and his engagement in the services for his autism, getting him routine daycare established, back and forth with transportation, working through all of that process, because that was the patient's number one priority. She was sitting with multiple hospitalizations, significant anemia, multiple comorbidities, and really her number one priority was her son, of course. And Nikita, through her willingness to go the long game, really, really, really importantly stuck with, okay, this is your priority and I'm going to be here with you as your advocate for your son. And once she understood that her most important issue was being addressed by the navigator, which had nothing to do really directly with her viral suppression, but it had everything to do with her viral suppression, right? And some of the motivational messages, and I'm going to stop after this and let Nikita talk about this, but one of those most important that just gave me goosebumps was when Nikita was giving the details about how she had never made the connection between her CD4 count of 3 and her multiple hospitalizations and comorbidities and the focus on her son and her not eventually being there for her son if she kept this same trajectory in place. Nikita, do you want to share that?
Yeah, sure, definitely. Because I was pretty much going off of like, hey, your son, and he needs you, right? And if you aren't around pretty much to be able to take care of yourself, like, let's go back to the drawing board. Like, what is a CD4? What is a viral load? Let's do that. And we actually sat down and like, just plain as day, like looking at her viral load and looking at a CD4, what exactly all that stuff is. And she was like, oh, I thought I was doing the right thing of what I was doing, and really getting down to the nitty gritty of exactly what was going on, because like on paper, she looked like an engaged person. She came to every doctor's appointment. She never missed any time somebody call her and say, hey, I'm just rescheduling this or something like that. She's calling people back. She was very, very, very engaged. So I was like, I'm a little concerned here. I don't exactly know, but doing more of that digging and understanding, like everything resulted right back to her son. Hey, I need to get to daycare. I can't get him to daycare. I need to put food on my table. I need to feed him. He's still, in, pull-ups, and I need to be able to help get that, but I can't because I don't have enough money. Like all these things always came back to her son. And I'm just like, oh, okay, as a mother myself, I had to, you know, be like, all right, we got to get the baby in line and we got to make sure that he's okay, because that is her highest motivation. If I don't have anything, and she didn't even have a good social network within her own family. Like it was just me really and her. Like she would call me, and she still does. She'll call me and it's after hours. So outside of that time frame of calling me and saying, hey, this is what's going on right now, I just need somebody to talk to. And just, you know, having those even little, you know, you go on Pinterest and the little cute little motivational things, thinking of you. And it goes back and forth with that trust building relationship, because that's something that she has always even checks on. Hey, happy birthday, you know, happy Thanksgiving. She's always keeping in contact with me. And that has helped her tremendously with having somebody in her corner.
And one of the other things, I just want to follow up on that, is notice that happy birthday and those things are all text messaging based. Mm-hmm. As direct line, direct access. This is not call a warm line. This is call Nikita's cell phone, call her, text her. Democratizing communication with patients is a key aspect of an unapologetically enabling intervention.
Thank you so much. We have a few comments in the chat. One from Robert Gross. Congrats on your success. Can you explain if and how the community health worker is the same person who does the navigation in the medical system, or are these different roles? Or is this an expansion of the role of the navigator to leave the brick and mortar of the clinic?
It's a great question. So when we originally designed the role, we wanted to situate the community health worker who was truly community facing. When you think about such community health worker models in a health system, and I know you already use a community health worker model at Penn, you really, really want to understand, is the job of this to really be more of a peer advocate within the system, or is it really to be, get out of those walls of that clinic and get into the community and understanding what, the patient, we do a lot of things as prescribers and providers where we're saying, okay, here's your 5 prescriptions, here you go. And that gap between here's your prescriptions, take them, and the patient actually achieving viral suppression for many patients is profound. And it's really when they leave the clinic that it becomes profound. And so we really wanted our navigators to be in the field, in the community, but also have the foot in the door so that they had access within the system to everyone they needed to access to basically break down the wall of the clinic and bring the patient, once they had their community intervention completed, back into the place in which they were going to achieve viral suppression.
And I think the other thing about the community health work, which I think is important to state, is that the community health worker very much looks like very often the people they're trying to serve, so that there is an understanding that they understand where the person is coming from. We talk about our Star Trek partners and colleagues. That is a whole other population that has been achieving viral life suppression has been a challenge for, but that community health worker is known and trusted by these kids who have experienced a great deal in their young lives. Or for our community health worker DIS person, that was a critical response to what people were saying, that I don't want to have to keep saying the same thing over and over and over again. How many times do I have to say it? I have it, can we move on? And I think that's been a very important part of this. And it's one of the things that really made the model so appealing to me, that at what point, Dr. Farley, you had pretty much same gender loving men, transgender, a range of individuals reflected in your community health worker core. And I think that's an essential piece of it. And the other takeaway message is what many of our community health workers are doing is they're advocating and listening, which we don't have time for very often when someone's tapping that watch in the clinical setting.
Thank you. We have a few more questions. We'll try to get to all of them, but if not, we'll bring them in our sort of group discussion at the end. Is there a large-scale system with one-to-one case manager / navigator case patient relationship sustainable over time? What other factors can come in to make the system quote unquote efficient and efficacious yet sustainable over time? I guess the question is around sustainability, particularly with caseloads.
Yeah, no, I think this is a great question. So you'll note in the data that I presented that there were 136 patients who did not have viral suppression. And when we started this out with a pilot program, Nikita's efforts, we told her that we really wanted, because many of our clients in this category are very high need, we wanted the community health worker to patient ratio to be around 30, right? Because you've got clients who need 115 contacts and really, really intensive level of intervention. And as you can see, it moved into very quickly 136 clients during this patient time. And that's because some patients would fall, they would get virally suppressed, they would maintain viral suppression, they would fall off the list, but that's a totality of all patients, right? But what I think was, Nikita during this time was really, able to motivate what's the right level of intervention. Sometimes it was just a text message for people. Sometimes it was, she had to repeatedly call and other types of services. But in terms of sustainability, I don't think for much longer a patient to community health worker ratio of 1 to 136 is certainly sustainable at all. We probably want to right size that to no more than 1 to 40. If a clinic just can't do more than that, 1 to 50 is probably no more than that level. Most importantly, we have to tie this, and one of the reasons we're measuring gross cost, and for Dr. Starbird on the call and other health economists with expertise there, those gross costs are probably shivering a little bit. And in our expansion, we are really thinking about how to measure time on task. So doing a time series analysis and then evaluating the cost per client, as well as the time both the community health worker spends on the intervention, as well as what does it look like based on per contact. So if I text a client 10 times in a given day and to achieve one goal of returning paperwork, how is that different than if I have to call them and spend an hour on the phone to do that same outcome? And trying to measure those kind of activities within the dose of the community health worker intervention. What we're hoping is once we have that data, because typically the case management intervention, whether it's nursing, social work, or community health worker, is a black box. You just do this community health worker intervention and we're not costing it out, we're not determining time on task, and we're not determining the dose of the intervention. So it's really hard to say who actually benefits with a low dose, medium dose, and high dose structure. And so what we're hoping to do with the expansion is really put some parameters around that and ultimately do a costing analysis of the intervention. We're hopeful that that data would then lead to reimbursement models in which community health workers might be able to suggest to Ryan White and we as the program would suggest to Ryan White that those programs should either provide FTE support or provide some level of cost reimbursement approaches for any patients that community health workers are able to re-engage in care and achieve viral suppression through.
Thank you so much, this answer. So we probably have time for one more question. Thank you so much for this presentation. I'm surprised that 70% of contact was via telephone, given the barriers mentioned, like burner phones. Did the program address changes in phone numbers? Were texting or apps like Facebook or patient web portal used to contact patients?
Nikita, do you want to take that one?
Yeah, sure. Actually, sometimes trying to, if anybody, I had 2 patients that did reach out and ask me if they're like, hey, do you have Facebook or something like that I'm able to get in contact with you, because if they're in Wi-Fi, that's some way that they're able to get in contact with. So that was 2 of my patients, but most of them usually were either hitting the ground running and going to last, addresses and doing those text messages, because sometimes people don't like to answer numbers they don't know. And if you just, text them and be like, hey, give me a call, my name's Nikita, and just leave it real bland and then have that conversation, they are more likely to text back or even sometimes email as well.
And you also, I think, purchased airtime and burner time. Time. So you might want to talk about that.
Yeah, I did. One of our individuals who he was actually homeless, and we had to go out into the community and where he was staying in like a little shedded area. And I'm like, well, in order for you to get back in care and us be able to communicate with you, I'm going to buy you a phone. And we did purchase a phone and some airtime for him to be able to keep making those appointments and getting in contact with us.
And that's an important thing to note, that we actually received, someone asked who's funding the project. It's funded by HRSA. And one of the things that we have recently learned is that we are allowed under emergent circumstances to purchase this, which is another key part of this model.
That's wonderful. Well, thank you so much for this amazing talk, and thank you for the audience for your engagement and all your questions. So now I am going to, we're going to take a small break, a 10-minute break, and we'll plan to come back at 10:25 for the research talks. Thank you so much, everyone.
Thank you.
Thank you very much for the opportunity.
Absolutely. Thank you so much.